Hi everybody, welcome to this very important, exciting lesson about history taking for patients that are on insulin. It doesn't matter where you work, either you can be working in the emergency department or the intensive care unit or even on the general peds floor. You can be a general pediatrician provider or an attending and a resident, you can be a medical student, and you're going to have to take this history. Two things to comment on are how aware is the patient on the actual personal regimen, and number two, how involved is the family with the patient's care and how much do they know the kid's own regimen. We're going to be talking about rapid acting insulins first, then long acting insulins, then pumps. So let's start with rapid acting insulins. The patients locally here use three types of insulins that are rapid acting and they're interchangeable: Humalog, Novolog, or Apidra. All three are given for two reasons. One, to cover a meal, and two, to reduce blood sugar. This is commonly referred to as corrections. However, sometimes we ask what's your correction and the patient actually gives a meal answer. He says, oh, I do 1 for 30, or I do 1 for 10, or I do 1 to 15. What they're actually quoting you there is their insulin to carbohydrate ratio. That is the same as saying 1 unit of insulin will cover X amount of grams consumed for each patient, and that number is different for each patient. The correction part can be quoted in two different ways. Either they're going to say, I have a sliding scale and this is my sliding scale, or they're going to say, I use a formula. They're essentially based on the same thing. Formula is a little bit more advanced, so patients that have diabetes for longer would tend to use it. The sliding scale is based on a range of blood sugars, usually starting from 200, usually going up by 100, and what we teach them is to have a specific number at each segment where they have to use to correct. This can be multiples of each other or they can be sequential numbers, but they just have to know those numbers. For the formula, they have to know a simple formula of blood sugar minus a number that is their target over another number that is their sensitivity factor. So remember, for rapid acting insulins, two things to know: meal and correction amount. The correction can be quoted either as a sliding scale or as a formula where they have to remember two numbers, the target and the sensitivity factor. Even if they don't know that that's what they're quoting, they know the formula. So let's move on to long-acting insulins. Long-acting insulins are commonly used once a day, but we're going to talk about both common regimens in the community. The long-acting insulins they're used once a day. They're given usually at bedtime and Atlantis or Levemir. The ones that are used twice a day is NPH, and that is because NPH lasts for about 12 hours. NPH can be given by itself or it can be given as a premixed insulin. There's two companies that make premixed insulins, Novolog and Humalog are the two names for them, and they have a ratio next to it, 70-30 or 75-25. The big number on that ratio is the percentage. That means how much percentage of the units that you're given is your NPH. So for example, if someone is taking 10 units of 70-30, 7 units will be NPH and 3 units will be a rapid acting insulin. But for both regimens, either QD or BID, we need to know how many units they're taking, and keep in mind that in the BID regimens, the morning dose is usually much higher than the afternoon dose, because we don't want to give them too much when they're going to bed. And we need to ask them if they had any missed doses. This is a very important question. Let's make a key point here. Patients on long-acting insulin will go into DKA for two reasons. Either they have an acute stressor, like a big infection going on, or they have to have missed multiple doses. So let's move on to talk about pumps. When we talk about pumps, it's important to realize that pumps have three components: the machine itself that has the insulin and certain settings, it has a tubing system, and then an insertion site that goes underneath the skin. So pumps use only rapid acting insulin. So the questions that we need to ask are exactly the same that we ask for the rapid acting insulins. The carbohydrate ratio is something we need to know, and the sensitivity factor or the correction is another thing we need to know. However, because they don't have any long-acting shots, they do have rapid-acting insulin going in the whole time, and that's the basal rate. That's how many units per hour the pump is constantly infusing. So the most important thing that you can probably do for these patients is to verify these settings by going into the pump with the patient's or the parent's help and get those numbers. Get the I to C ratio, the correction, and the basal rate. But remember, because we have a mechanical system, things can go wrong. So specific questions to the pump should include, is there any problem with the machine itself? Have you noticed any error messages popping up on the screen? And a pump that's not working, it will usually tell his patient. Have you noticed any kinks with your tubing system? Those tubing systems are a few inches long, so they can get kinked under clothing or depending on postures. Or has there been any problem with your insertion site? Sometimes the insertion site stops working, is blocked, or it's actually leaking insulin out of the subcutaneous space on the skin. So how often do they change the site is a very important question, because if they leave it longer for 3 days, it might not be working anymore, and if they had any actual problems, any swelling, any redness with the site itself. So let's zoom out and review what we talked about. We said for rapid acting insulins, we need to know how do they cover for meals, and how do they correct for high blood sugars. This can be either as a sliding scale or as a formula. For long-acting insulins, 2 questions for either once-a-day regimens or twice-a-day regimens. How many units are you taking, and have you had any missed doses? Remember, they need multiple missed doses to go into DKA if they don't have an acute stress. For patients on pump, we need to ask the questions that we ask for the rapid-acting insulin, the subcutaneous one above, so carb ratios, corrections, but we also need to know what the basal rate is. And because it's a mechanical system, we need to know if there's any errors with the pump, any kinks, or any side problems. At this point, I want to make a very important distinction for these patients. If the pump stops working within 6 hours, they can go into large ketosis, so they can and will go into DKA overnight. Thank you so much for listening, and make sure that you check out the other endocrine videos online.